call upon Dr. Jitendra Jethani now for this paper on comparison of defocus incorporated multiple segments versus highly aspheric lens set on myopic progression.
Yeah. Should I start?
Yeah.
Good afternoon, respected judges. We all know that myopia prevalence has been increasing dramatically, and in the recent decades, including in India. Now it is estimated that by 2050, in India also, we will have around 48% of the patients will be myopic. So what are the key factors which are responsible for this growth? Most common now has been documented as peripheral hyperopic defocus. There is a defocus of these rays which are coming posterior to the retina, and this defocus is creating the growth, axial growth of the eyeball. With this background, two new spectacles, MyoSmart by Hoya and Stylus by Essilor, have reported variable success in controlling myopia progression. With this background, we did a study to compare defocus incorporated multiple segment, that is DIMS, versus highly aspheric lenslets, that is HALT, on myopia progression. Now, our financial disclosures. The children were selected if they were prescribed either Hall or DIMS lenses, were younger than 12 years, and were without any other ocular abnormality like strabismus, amblyopia, or any other ocular or systemic anomalies. All the children were non-responders to atropine, and they had already stopped atropine 3 months prior to being given glasses to account for any rebound effect that has taken place. The standardized 1-year spherical equivalent refraction and axial length changes from baseline were included. Cycloplegic autorefraction, dynamic retinoscopy, axial length was measured with NIDAC AL scan biometer, and the average was calculated. So the primary outcome for this particular study was spherical equivalent refraction, which was calculated by adding the spherical with a half of cylindrical power. And the secondary outcome measure was obviously the increase in axial myopia, that is axial length from the baseline. The minimum follow-up period was 1 year, and the outcomes were compared for the measurement from baseline to 1 year. The baseline was once the atropine was stopped and we had waited for 3 months. Only the results of right eye were compared to avoid any confounding bias. We are not going. So a total of 38 children were included in the analysis, 16 in the Hall group and 22 in the DIMS group. The mean age was comparable. In DIMS group it was 9.6 years, and in Hall group it was 8.6 years. Pre-intervention, we can see that there is a spherical equivalent progression of 0.76 in DIMS group and 0.86 in Hall group. And pre-intervention axial length progression is also given, and post-intervention after 1 year. So this is per year progression, which I am showing. The differences in outcome between the two groups were analyzed with unpaired t-test. Results were two-sided. P-value of less than 0.05 was considered significant. To curb the myopia progression, these are the two new glasses which have been launched around 2-3 years back. DIMS was launched 2 years back. Hall was launched 1.5 years back. Now, there have been some morphological changes between the glasses. The DIMS has around plus 3.95 diopters of peripheral refraction, whereas Hall lenses have a variable peripheral refraction. And this has been shown that Hall lenses do fare better than DIMS when there is a head-to-head this thing. So we compared this in Indian eyes. This is the first study to compare the two aspheric lenses or two peripheral defocus lenses in Indian eyes. We all know that the neurons are more densely packed in the central retina, but the peripheral retina, total accumulated number of neurons are far more, and therefore technically if you have a larger area of functional zone, that should work better. So Hall lenses have a larger defocus area than the DIMS lenses, and they did show a better myopia control, but the control was not significant. So statistically it was not significant. So we conclude that both the lens designs are equally good. Hall lenses were slightly more effective, that is clinically, not statistically. And although both lenses are effective and they can be used to reduce or slow down the progression of myopia, more long-term studies are needed to actually prove the efficacy of lens and also to see whether there is any rebound once we stop using these glasses. So thank you so much for the interest. Thank you.
Thank you. Thank you, Doctor.
I have a question,
Yeah.
Jitendra.
Yes, ma'am.
What is the cost of both of these lenses?
Both the lenses are almost same cost, so that to the doctor it is 8,700 rupees and MRP is 15,000 rupees.
15,000.
So that was one of the major reasons why we had given it in patients who were progressing beyond atropine. So all the patients were atropine non-responders. They were not first line therapy.
But how long did you wait to decide that they were non-responders?
We waited for almost 8 months, madam.
Okay. And there was absolutely no...
No,
The
there was
myopia
absolutely,
was
yes.
progressing.
So basically what we did was we gave them atropine. Principally what we do is we give them atropine and after 6 months we reassess and increase the dose of atropine.
Okay.
And we increased the dose of atropine, they still did not respond. So after that we waited for 8 months and then we waited for 3 months as a washout period. So if there is any rebound of atropine, that should also go away.
Okay. Thank you.
So
Yes, sir.
basically, your the mean age group was 8 to 9 years old.
Yes, sir.
You tried atropine for say nearly 7 months, waited, so another 1 or 2 years gone. So your then from that is your base point, and you are
No. We started when they were 6 years of age. This was the age when they were given glasses. This was the mean age when they were started on glasses.
right. But the atropine, it's a non-responder to atropine, so they were increasing quite a lot significantly.
Yes. They
before
were
that?
increasing
How
more
much?
than 0.5 diopter per year. That is the standard
0.5 diopter
definition.
per year.
That-
So if they by that time another 1 or 2 years gone, so by that time usually the progression will be less anyway, isn't it? So say
Sir, that holds
year
good
from
for-
say if it is recruited at 9 years age and you are starting the treatment say around 12, 10, 11, then usually the progression that time is already reduced.
Sir, that is true for atropine also, no? If we are treating them on atropine, their progression should reduce over a period of 1 year with age.
No, but that doesn't always happen, doctor. It doesn't always happen.
Yeah, no, it doesn't happen.
See, because whatever may be written and whatever the studies may show, but each patient's body is unique. And they respond differently. Because I have seen myopia progressing even at the age of 40.
Yes.
When we say kids should stop progressing by 18, 20, 21 max, myopia should stop progressing. It doesn't work. The body follows its own rhythm.
Its own rhythm.
Thank you.
Thank you so much.
Yes.
Thank you.
Now